So, as you know, it's an important issue actually for women postmenopausal women who have breast cancer, because very often they have hormone-sensitive tumors and they will have to receive hormonal therapy in adjuvant setting. And this hormonal therapy consists very often in an aromatase inhibitor. And this aromatase inhibitor diminishes the levels of estrogens, and we could expect to have cardiovascular issues because we know that women are at risk after menopause for cardiovascular issues. And you know, the population is aging. The mean life expectancy in Europe and France is 85 years old. And these women have also comorbidities. So the association of treatment plus comorbidities can increase cardiovascular risks. And we know very well, on the other side, that when women take hormone replacement treatment, they decrease the vascular risks. So we have to very well evaluate the balance, the risk on one side to have recurrences and the risk on the other side to have safety concerns and to have complications with the drugs. So the three different drugs we can use, the three aromatase inhibitors, anastrozole, letrozole, and exemestane, have replaced the tamoxifen. And the tamoxifen had a very well-known role of protecting from cardiovascular issues. So now what can we say? We can say that when we look at the trial, the results of the trial, when the comparator is tamoxifen, as you can see on the slide, for the first trials, ATTACK, BIG, IES, ITA, you have TAM as a comparator, and you are able to see that there is a difference in terms of hypercholesterolemia. So when women take aromatase inhibitors, cholesterol levels are increased. But it's a false way to interpret the results, because if you look at what we were able to measure through the big 198 trial, you see at the first curve, the upper curve, remains stable all the trial long. That wants to say that this curve corresponds to the cholesterol levels for women who take letrozole, so it's the aromatase inhibitors. You don't have really an increase in terms of cholesterol levels, but when you compare with the other curve under this one, you see that quickly, 6 months after women take not the aromatase inhibitor, but the tamoxifen, they have a decrease by 14% of cholesterol levels. So in fact, the right answer to what we see previously, I cannot go back, I'm sorry, we'll go backward, sorry. What we said previously is that, in fact, you have no real increase in the cholesterol level for letrozole and aromatase inhibitors, but you have a decrease with tamoxifen. And I was able to show in the previous slide that in another trial, the trial comparing aromatase inhibitor letrozole to placebo, you have strictly no difference. So the comparator is the main responsive of the differences in terms of cholesterol levels. What about cardiovascular events? We were able to show in the different trials that the relative increase in cardiovascular events was not significant. You don't increase really the risk relatively. But the absolute increase exists, is small, between 0.3% and 1.3%. And the relative increase when you compare with the placebo, what I said previously, absolute increase versus TAM, it's a little bit increased. But when you take a placebo, you have also no increase in terms of cardiovascular events. So here also, what we could say when we look at the data from the trials is, till now, with the data we have been able to analyze, there is no differences. But it's very important to tell you that the way the data were collected was very different from one trial to another. We could say that, especially in the big 198 trial, using letrozole, we were able to collect very interesting data and all the data because we had pre-specified events to check. But for the other ones, the first trials that were started 10 years ago, these data were not mentioned, and we are sure that some of the side effects were not really collected. That's why the American Society of Clinical Oncology told us 3 years ago that the data were insufficient to determine exactly the late risks for the woman taking aromatase inhibitors. I think that this judgment is a little bit hard, and with our daily practice and the fact that we use these drugs in trials for more than 10 years with a huge number of patients treated a long period ago, we can say that surely the late risks are not very important. So I would come back on the real risks concerning the patients receiving aromatase inhibitors in trials and the global population. And we made a comparison with an age-matched population of postmenopausal women who did not receive any treatment. And you can see, globally, at the end, total, for letrozole, 1.9 event per 1,000 person years. With tamoxifen, you have less. As I told you, tamoxifen decreases vascular risk, decreases cholesterol levels. And general population, it's between 1.9 and 2.2. So the conclusion now is clear. You don't increase the risks when you give an aromatase inhibitors to women that are selected. I want to say that we have to take care about hypertension, diabetes, and so on. But if you take care about that, you will not increase the risks. And you will increase the cure of these patients, and you will diminish recurrences. So actually, the conclusions are clear. There is no differences between the two drugs in terms of safety issues, cardiovascular issues. We are making new trials, and 2 trials have ended accrual. It's the MA27 and the phase trial. Here are the design of the 2 trials. And these trials, we use all the drugs that can be prescribed to our patients. For the phase trial, we compare letrozole to anastrozole, and for the MA27, we compare anastrozole to exemestane. And through these 2 trials, in which more than 4,000 people will be included, we shall measure very strictly all the parameters, cholesterol levels and triglycerides, HDL, LDL cholesterols, and also we shall manage them carefully concerning cardiovascular issues. So we can say that now work is in progress, and in the near future, I think that within 2 to 3 years, we shall have interesting data concerning safety, and we shall be able to get good data to our colleagues of the American Cancer Society, and perhaps they will say, now everybody knows very well what happens when women take 5 years long aromatase inhibitors. Thank you for your attention.